Hello there, my name is D.E. Foster, and I am host of the Benzo-Free podcast at Easing Anxiety. And welcome to the Bind Roundtable, featuring the Benzodiazepine Survey Research Team. This roundtable was produced to support the publication of our team's third and final paper of the Benzodiazepine Survey of 2018 and 2019. In this paper, we formally introduced the term Benzodiazepine-Induced Neurological Dysfunction, or BIND. Please join our moderator, Angela Peacock, and several members of the research team for a lively discussion of benzodiazepines, their symptoms and adverse life effects, and this protracted condition we now call BIND. Angie, take it away.
Hi, everybody. My name is Angie Peacock. I'm a social worker and a coach within the community. Today, we're going to be doing a roundtable, and we're going to be discussing some new research coming out about benzodiazepine-induced neurological dysfunction, or known as BIND.
Yep.
All right, so let's just go around. Everybody introduce yourself. Just tell us about your work, how you came to this team.
Well, I'll start off since I'm next to you,
Yeah.
and then I'll pass it to the next person. Okay, my name is D.E. Foster. I host a site called Easing Anxiety and host the Benzo-Free podcast, which helps support people dealing with benzodiazepine injury. And I'm also a co-chair of the Benzodiazepine Action Work Group, along with Dr. Alexis Ritvo, and on different research teams like this one and committees and stuff, and just keep myself busy. So that's me. I'll pass it off on to Alexis. Since I just mentioned you, I'm going to pass it to you.
Sure. So I'm Alexis Ritvo. I'm a board certified addiction psychiatrist and an assistant professor at the University of Colorado School of Medicine, and a program director for Addiction Psychiatry Fellowship. Came to know Dee and as well as Dr. Christy Huff on here through our work with the Benzodiazepine Action Work Group, as well as also our work here as this research group through the Alliance for Benzodiazepine Best Practices, where I'm also the medical director, and have just had an increasing interest in helping patients that are prescribed benzodiazepines and having adverse effects, figure out how to minimize those effects and decrease the risks, and taper off or decrease as much as able. I'll pass it along to Dr. Christy Huff, since she's below me in my view.
So I'm Christy Huff, and I'm director of Benzodiazepine Information Coalition. We're a nonprofit that educates about the adverse effects of prescribed benzodiazepines, and I have lived experience with benzodiazepine withdrawal and BIND, and I've been involved with the survey basically since the beginning. I was approached by Jane McCubry, who was the survey designer. She had actually been harmed by benzodiazepines as well, and so together we put together the survey questions and administered it in several of the benzodiazepine support groups, and then later on a research team was formed, and here we are on to our third paper, and it's just been a great experience so far.
You just answered her first question. You
first
jumped ahead, but that's great. We'll feed off that in a second there for you, Christy.
It's just a natural progression.
It is. But your turn to hand it off to somebody.
Reid.
Hi, my name is Reid Finlayson, and I'm a psychiatrist and addiction medicine boarded professor of psychiatry at Vanderbilt University. And I got involved with benzodiazepines through some lived experience with mental illness and some research in the early 90s that I was observing. And I was excited by the survey that Jane and Christy so ably put together, and was delighted to be able to help out analyzing it and interpreting it. And I'm going to call on my mentor and research expert to introduce himself, Dr. Peter Martin.
Thanks a lot, Reid. I'm a professor of psychiatry and pharmacology at Vanderbilt University School of Medicine. I'm also an addiction psychiatrist. I've been studying central nervous system depressants since the mid-70s of the last century. And I've actually done research on benzodiazepines since about that time, when they first came out. And, you know, I have been struck by how serious a problem it is. My perspective has always been that it's very easy to discontinue patients from benzodiazepines, because I developed a technique to do so back in the 70s, and it seemed to work really well until I met a group of individuals who have helped to point out to me and to actually convince me of what a toxic problem this can be for the individual's life, and for, you know, all the different aspects of living. So I am very pleased to be part of this group. Reid got me involved, Reid Finlayson, and I've just loved working with this team.
You guys all have impressive histories, and you bring such talent to this team. So let's talk about the papers, the research that's come out. Maybe start with the survey. Like what was in the survey? What were you looking for? And take us through papers 1, 2, and now 3.
Christy, you want to start off with maybe how we got started?
Sure. So I'll just recap a little because you've heard some of it. I was approached by Jane McCubry, who's a communications specialist, and she basically designed the survey with my input. We looked at basically benzodiazepine withdrawal scales that were already in the literature, and that helped inform the survey questions. But we also incorporated our own lived experience as well, and also my experience in advocacy. You know, I've spoken to many other patients dealing with benzodiazepine related issues in the support groups. And so all of that informed the questions that we asked in the survey. And specifically, we're asking questions like what benzodiazepine the patient was taking. We wanted to know about the symptoms that they were experiencing, and we asked about 23 specific symptoms that seemed to be fairly common. And we also asked about life effects as well.
So then paper 1 was centered about experiences with benzodiazepine use, tapering, and discontinuation. And then paper 2 was enduring neurological sequelae of benzodiazepine use, an internet survey. So take us through paper 3. What is the pending research that's coming out?
Alexis, since you're leading that one, do you want to take that?
Yeah. So paper 3 was further analysis of the results from the survey, and with a real focus on, so we had a group of us along with several others that have been part of the Alliance for Benzodiazepine Practices, and that are various clinicians and researchers, decide upon what we wanted to call this protracted withdrawal state that we've been seeing in folks that are on prescribed benzodiazepines and in the process of tapering off, and even when they discontinue and feeling like protracted withdrawal wasn't adequate. So part of the paper was describing the process of how we came up with the name Benzodiazepine-Induced Neurological Dysfunction, or BIND, and then also analyzing the data to look for the results that supported the name BIND. So what are the variety of symptoms, as well as, especially as Christy already mentioned, the significant life effects that these benzodiazepines have on individuals as they're tapering, and even once they're off of them. And so that was the third paper, is really trying to make a case for BIND and demonstrate what unfortunate effects these medications have.
Yeah, I might add a little bit to it, and then I might see if Reid and Peter might be.
Yeah, you know the data very well.
Yeah, I'm the data guy.
I'm talk about the
data
numbers.
So, yeah, one of the things we noticed specifically was the length of some of the symptomatology that was asked about. And we noticed that typical withdrawal syndromes like hallucinations, seizures, whole body tremors, they were showing up in a very short duration on there. So the first 30 days, what's usually attributed to acute withdrawal. But then we noticed different symptoms were more the longer term, months or years lasting.
I think the really important observation from my perspective was that I had always thought of benzodiazepines as a short-term phenomenon, that you withdraw people, you get them over the really hard hump of getting them off the benzodiazepines, and then you forget about it because they're back to normal. In fact, that's what we're taught in medical school. That's what I wrote in pharmacologic textbooks, chapters that I've written in pharmacologic textbooks. And to me, it was eye-opening that there were people who had symptoms that were really quite devastating to them. And they came, they were there a year or more after the person came off the benzodiazepine. It's almost as if the benzodiazepine had altered how the brain works. And so it wasn't, it was something that we could not get rid of by stopping the benzodiazepine. It's something that was residual. And so the question really is, are withdrawal and is this prolonged set of symptoms, so-called bind, a different set of conditions? And I think that was the eye-opening observation, that in fact these are likely two different insults on the central nervous system. And by the effects on the central nervous system, it affects the entire body. So because of course you know that all the systems of the body are innervated by the central nervous system in one way or the other. So that's my observation.
Dr. Finlayson, can you say what surprised you about the research, or what did you learn?
I would agree with what Peter said. I think it is a really important finding, because I think we have to explore this more and find out. Like it was just a survey paper of a number of people selected because of concern that they were having reactions or symptoms when they were trying to discontinue benzodiazepines, or they had completely, in many cases, discontinued them, and these symptoms persisted. What we need to find out is to refine the cluster of symptoms, and then look for it sort of before and after in a different type of research, before and after starting the benzodiazepines, to see if we can learn more about the phenomenon. What our survey lacks is a careful understanding of the sorts of problems that people were prescribed benzodiazepines for, and what illnesses they may have had that were developing independently. We just don't know. But it certainly is an important finding, and something that deserves further research.
Thank you. So can someone answer, how did you finally settle on the term BIND, benzodiazepine-induced neurological dysfunction? How did that come about?
That would be a Bernie question. Just so you know, Bernard Silvernaill, another member of our team, but not available to join us at last minute. He had to fly somewhere. But I don't know if somebody else wants to take that one for now.
I mean, I can try to describe now I'm trying to look for the exact process we underwent. Anyone remember the exact?
It was a Delphic
is the word you're looking for.
Yes.
Delphic?
A Delphic process.
approach.
So we went through multiple rounds with this group of experts, 27, if I recall correctly.
Pretty close.
Where we put forth all the terms that folks wanted to consider, from benzodiazepine protracted withdrawal, benzodiazepine post-acute withdrawal, various, I think we talked about benzodiazepine-induced psychological dysfunction, neurological dysfunction, and we just kept going through process of voting on all of them, and then we narrow down the list a little more based on which ones got votes and which ones didn't at all. through multiple rounds until we got to the final potential names, and people kind of put forth their argument of why we thought one name versus another would be a better choice. And I think what I recall, and others can contribute what they remember, is that we thought bind was helpful because by focusing on neurological dysfunction, it would encompass both the psychological effects and the physiological effects that individuals harmed by benzodiazepines experience, and that if we only called it psychological or psychiatric, that would kind of pigeonhole it too much and kind of risk what we think a lot of patients already experience, which is being told this is, all in your head, or only as, part of maybe the original mental health reason this might have been prescribed for many people, if it was sleep or anxiety even, and that didn't represent what we're seeing, which is this really broad effects of this medication throughout the nervous system and the brain. So that was how we got to bind. Plus it makes a nice acronym, which is always good to have, and easier to refer to. I don't know if others have other recollections or inputs about the term.
Well, I would just add the appropriateness of bind, because I was impressed by the number of lifestyle disabilities, from work, relationship, marriages, that people appeared to be suffering problems with, or in a bind.
Yeah. Oh, good point. Wow.
Yep.
Wow.
Yeah, I had a
I
lot of.
mean, maybe it's worth it. I'll go ahead and read the definition as well.
Great,
I think
thanks.
that so it describes a constellation of functionally limiting neurologic symptoms, both physical and psychological, that are the consequence of neuroadaptation and or neurotoxicity resulting from benzodiazepine exposure.
I'm wondering, this is one, as a member of the team, one of the things I was confused on, and I wondered if maybe one of the doctors, which is everybody but me, can elaborate on, is neurotoxicity and or neuroadaptation some of the language we use in the paper, but can you define the difference there and why those terms? I know, Peter, you kind of presented some of those terms there, but for people like myself who aren't medically trained, how do those differentiate, and why are those terms used in the paper?
Okay, I think that it's really important, and is the crux of what we're talking about, is to understand these two concepts, and I thank you for bringing it up. Neuroadaptation is actually a physiological response to chronic exposure to a drug, acute and then chronic exposure to a drug. Things happen within the neurons that try to equilibrate a system. So there are changes within the neuron that are in opposite direction to the effects of the agent, the drug. It's basically equilibrium. The body wants to maintain homeostasis, which means a level, unchanged system. So if a drug like the benzodiazepines activates benzodiazepine, well, GABA receptors, one of the GABA receptors are inhibitory neurotransmitters. So if it activates GABA receptors, what the body tries to do is increase excitatory receptors and diminish the effect of GABA.
Mm-hmm.
So the GABA receptor changes its form so it becomes less effective, because basically the brain wants to be level.
Right.
Okay? That's neuroadaptation. Neurotoxicity is pretty much like going up to your car and slashing the tires. Okay? The car's not going to go really well because the tires don't work anymore. There is damage to the neuron.
Mm-hmm.
And that's not a physiological insult. That's a pathological, toxic insult. And so what we're saying is that the acute withdrawal that the person experiences, the one that happens right after they stop using the drug, is really that physiological normalization of the brain. So it's a reversal of the pharmacologic effects of the drug. Whereas toxicity is something that stays there even when the drug is discontinued. So is that clear?
Crystal clear. Yes.
Okay.
Thank you for explaining that. And I think I want to go to the adverse life events. So that's on the paper 3. These changes impact your life. It's not a little thing. So can you talk about what did you find and what is going to be in paper 3?
I actually have it in front of me, but if somebody wants to start off,
I have it in front of me. I'm happy to say. Yeah, I mean,
Alexis, yeah.
The list is unfortunately very long.
Mm-hmm.
And includes, things that we've all seen from, so I'm trying to see which ones would be most relevant. So we look both at specific life consequences that folks attributed to the benzodiazepine use due to the symptoms they experienced from the benzodiazepine and tapering or discontinuation. So significantly affecting relationships, suicidal thoughts in 54.4% of individuals, losing a job or being unable to work because of symptoms in almost 50% of individuals, significant increase in medical costs, loss of wages, loss of savings or retirement funds, violent thoughts or actual violence against others. I mean, those are all the initial high level ones that we saw. So really, I mean, I think what's remarkable is that it affects all areas of life, right? It negatively impacts all areas of folks' lives, and not just limited scope, feeling unwell for a brief period of time.
To me, I'm just really proud of this team, because I think this is the start of an evidence base for something to be recognized. Because right now the patients, if the doctor doesn't know what it is and they can't recognize it, they can't have disability payments or treatment for it or support. Mm-hmm. And a lot of this is, loss of income, loss of security, moving in with family. We all have seen it. So I'm really proud of that. So for you all, so what's next for this team after this paper comes out? What's next?
Working on that now. So
yeah, almost there.
Who wants to pick it up?
I think Reid pointed out the major issue, and when he said that there are some real problems with our paper. One is that it's a group of people who, by definition, they were on a website that dealt with problems associated with benzodiazepines. They were a selected population, self-selected population. Mm-hmm. So I think the really big test will be, can we identify these problems in a large sample which are not self-selected? Mm-hmm. Can they be identified in a population of patients? And if we do that study, we will know how common it is, because that's really vital. That's the question that I think everyone is asking themselves. If I take benzodiazepines, how likely is it that I'm going to have bind? And I must assure you that we have no idea. We have no absolute idea. Mm-hmm. So you're going to have to do a survey type of a population that is not self-selecting for having problems associated with benzodiazepines. That's really the next step and the vital step, in my opinion.
Which I think might be kind of hard, just because of I mean, I don't know how much you guys know about me, but I see over 100 patients affected by this and other meds within my group. And I would say it's very rare to have a person just on a benzo. Very often it's a mixture. So that leads me to the next question, kind of, do we know anything about the long-term effects of other drugs similar to benzos?
Like psychotropics and antidepressants and
Yeah,
stuff like that.
antidepressants, antipsychotics, anything. I mean, this is the start of the benzo research.
Well, since we have a few addiction psychiatrists here, they might be able to help with that a little bit. So.
I mean, there's increasing research on it. Not as much as one would hope, given how much we use these medications. And Dr. Finlayson and Dr. Martin might be able to speak even more to this. I mean, I know, we've seen increasing studies come out about how we should be more cautious with tapering antidepressants, with tapering antipsychotics, with distinguishing what's a return of symptoms versus discontinuation or withdrawal symptoms, that we need to be doing informed consent with patients, that these are risks that come with all of these medications that we prescribe. I know I can say I still see many patients that do get, great benefit from some of these medications, but that doesn't mean they're without risks or long-term effects. And we don't have good research that's really said what are the potential long-term effects with some of these medications. Some of them we know, like antipsychotics, we'll probably do a better job about educating some folks about their risks. So yeah, it's complicated because you're right. If a patient's on one of these meds, they're more likely to be on another. And that further complicates things. I do think we need more research to really look at, first, as Peter mentioned, how common is this in a more general population prescribed these medications. And then I think, as the group knows, I love to refer to, let's take, look at what's been done with long COVID and being done. How do we take something that has such wide ranging symptoms and try to tease apart which ones are really more particular to this, to bind, and which ones are more universal. And also then that, I think, in turn will eventually help us try to understand more the mechanism that's at play. Why is it that certain individuals are so exquisitely sensitive to this? And that you do treat some other individuals that seem to have very minimal, dysfunction or disruption coming off these medications. And it's just not well understood. And I think I see a real parallel to what we see with long COVID, with some people just being completely debilitated by it. And other folks, maybe it's short-term or intermediate, and other folks, almost not affected at all. And that sometimes the first time you have no effect and you could get COVID again and then have long COVID. So I think that there's, something similar as far as happening in the nervous system, maybe the immune system, who knows.
All right, so that leads us to our last question. Are there any new research projects coming out of this? Any new research projects on the horizon about benzos specifically?
Well, for this team, we're looking into them, so we can kind of go around the room here and talk. I know Peter and Rita both kind of headed off. Dr. Finlayson and Dr. Martin are working on that area. Dr. Ritvo is leading up some other ones. And I know Christy and I have been working on some other stuff. So each one of these, I think we kind of broke off and started to investigate different areas. I don't know if Christy, you want to start off with talking about some of the things we're looking into?
Dee and I had looked into doing a project looking at kind of a narrative study of Benzo Buddies, the website, where a lot of people post about their experiences with benzodiazepine withdrawal, and so we're going to analyze some of the narratives and kind of look at some of the symptomatology and life effects, sort of similar to our survey, but maybe in a larger population. And then there's some other studies that we're looking at as well, and I'll let Alexis and Reid and Peter get into those.
Yeah, so we're, I guess, a precursor to, I think, what Reid and Peter are hoping to do, and the group kind of tags along in that we all support and encourage each other's research and end up involved. So we're engaging in us trying to do systematic, it will likely become more of a scoping literature review for the symptoms of bind and more projected withdrawal and long-term adverse effects of benzodiazepines. The literature is pretty sparse, unfortunately, but that just speaks to the great need for more research. But trying to do it in as systematic a way as we can to really say what is the quality of the literature that does exist on bind related symptoms, and where is the need for more research to try to further distinguish what is bind, how many people does it affect, what are the symptoms. And then I'll let Reid and or Peter discuss about what the next steps with that piece are.
Well, I think my concern is about the overuse of benzodiazepines, and I still question their effectiveness in treating anxiety. They're basically anesthetic drugs. You know, there are injectable forms of benzodiazepines like Versed that are used for surgical procedures, and I'm concerned that they actually limit the ability to think through situations and learn from mistakes. And the other aspect of it is I've experienced a lot of people having increased symptoms of depression when they're taking benzodiazepines, and suicidal thinking, particularly there's a lot of research in the VA, Veterans Affairs community, that the benzodiazepines actually make things worse for PTSD and cause, or at least are associated with veterans starting to think about suicide when they're on these drugs. And it feeds into the opioid situation as well, in my experience, because so many people with overdose deaths have the benzodiazepine drugs in their system. So, I mean, it's a huge public health problem. Peter, what do you want to add?
Well, I am struck by the toxicity of benzodiazepines, but I'm also struck by humans, patients I see daily, who I tell about the fact that benzos are not good to take, and I have to fight with them to get them off. That they are very resistant. And I think part of that resistance may be that it's very painful to come off benzodiazepines. It's very painful. So I think we're in a paradox here, because on one hand, we'd like not to damage the brain with benzodiazepines. And on the other hand, benzodiazepines make people feel so good initially. They feel as if their problems are alleviated by the benzodiazepines. And that's a paradox. So here I am in the position of telling patients, maybe you should get off the benzodiazepines, and they're asking not to get off the benzodiazepines. So a large part of the process is establishing a relationship with the patient whereby the patient trusts you and the patient believes that what you want to do with them is for their benefit, rather than taking something away from them that is so valuable to them. And that is really, really hard for both the patient and for the physician or the provider. So I think that our work is the beginning of educating both patients and physicians about the fact that there is a real problem here. There's a paradoxical problem that the medicine works too well in the beginning, and it does too much harm throughout its use.
And as you start to taper, especially if you taper too quickly, right, or discontinue, people feel so bad that they can't imagine.
They can't imagine a life without benzodiazepines.
Well, yeah, and I would say from personal experience and the people I work with, when you have increased suicidal thoughts and you feel more depressed and you feel more anxious, of course you want to take the benzo because you feel like it's helping. So it's even confusing for a patient to think, what do you mean the medicine? This is helping me.
Yeah.
I need
I
it.
can't imagine not having it and feeling worse.
Let me just assure you that if you have a compassionate doctor, it's confusing for them too.
Yes.
If you have, and that's why it's really important. And I think Alexis and Christy and Dee, who are engaged in education, are fighting a really large part of this battle. Because let me just tell you that our working together as a group has taught me something. I believe I was a world expert in this area, and I never realized how toxic this would be. I stopped at the withdrawal syndrome. I didn't go on. And I think the other point that we didn't mention, which is really, really important, and in this paper, we tried to demonstrate that the components of bind were distinctly different. The components of bind that the individual experienced were distinctly different than the symptoms for which the benzos were first prescribed, which is consistent with something emerging de novo as a result of the benzodiazepines, with the limitations of our study, that this is a selected population. And I think ultimately what we want to do, what Reid and I are working on, is trying to develop a protocol whereby we can identify all the people in our hospital system who are on benzodiazepines and try to study what the consequences of that are for them. That is, not go in and study people who are complaining, but to study everybody who's on benzodiazepines and see how common these bind symptoms are.
Yeah, and we hope to do that with a large data analysis and data mining in a university medical system in cooperation with the University of Colorado, where Alexis works.
So this is one of my own questions. This is all like patient-led survey data, outcomes, adverse life events, these things. Is there any effort to find out what is happening in the body? Like, what is bind exactly?
There is some research, but there's a real paucity of research. But there is some research emerging, which we quote in the paper, in the discussion section of the paper, suggesting that some aspects of the cell are actually damaged by chronic benzodiazepine use. Some aspects of the neuronal cells.
Got it.
So the cells become injured, not working quite right because of exposure to benzodiazepines.
That it's important too that we narrow down the symptoms of bind, so we know exactly what we're looking for.
That's a good point. Good point.
Exactly. Yeah.
Like points you in the direction of where to look.
Right.
When you find out what exactly, how does it show up, and then where do we look?
Yeah.
This is good. So earlier I was talking about, it's kind of rare to see a patient only on a benzo. Sometimes if they're on a benzo, they're also on antidepressants or antipsychotics or something else. Is there any effort to differentiate between the benzo long-term effects and the antidepressant long-term effects?
I think that both concepts are so new and so poorly understood that we need to learn a lot more about the situation before we know what to do, basically. I wanted to add that back in the 90s, I had the privilege of observing a very careful study of the treatment of anxiety in the form of panic attacks and agoraphobia that was very well done and occurred in populations near Toronto, Ontario in Canada, and in at the Maudsley Hospital in London. The late the late Dr. Richard Swinson in Toronto and Dr. Isaac Marks in London did an extensive series of studies on the treatment of anxiety in the form of agoraphobia and panic attacks. And it was very tightly done, very well done. And what they showed is that the people who took benzodiazepines didn't do quite as well as the people who took placebo, and both groups had a psychological treatment. But a follow-up paper showed that the people who gave credit to the medication, in other words, they felt that the benzodiazepine was really helpful to them, were the people that had relapses in their symptoms much more often than the people who believed that they had, their efforts in psychotherapy had improved them.
Interesting.
Last question. This is it, right?
Sure.
And then we'll close. Okay. So I think this is the last question, but we've talked a lot about neuroadaptation, neurotoxicity, damage, cellular damage, all these scary things for the average patient to be listening to right now. So can you offer any hope? Like, what kind of healing do you see maybe as, like Dr. Ritvo, when you work with a patient who comes off? Can you all offer some hope from your perspective?
I'll kick it off since
Okay,
I'll go around this way because I've been so busy listening to all the experts on here. They're amazing.
Yeah.
But I know from my standpoint, from working with the people, doing the different work with the podcast and everything else, is just see a lot of healing going on. I mean, you can't work with this group of people long enough to not see the progress people made. I know I've made progress. You've made progress. Our lives have gotten significantly better. We do heal. None of us can speak, I think, to absolute knowledge about permanence or not, but I know I see people healing every day and getting better. So maybe go around the board and see what everybody else take is on. That would be great too. So, Christy, you want to dig into?
Yeah, I'll chime in. So, I mean, I see the same thing as you, Dee. Working in advocacy, I talk to a lot of people, and it seems like the normal trajectory is that people tend to get better over time. Their symptoms diminish in intensity, and their function improves. That certainly happened in my case. I'm 4 years free of the benzodiazepine, and while I still have some lingering symptoms here and there, I'm pretty much back to a normal life. And it can be a long, slow process. So just don't give up, but that healing certainly does happen.
I think in the area that we work, that probably the most effective ingredient of healing is connection with other people. And I think that we tend to downplay that way too often. The problem with the GABA receptor drugs like benzodiazepines, and incidentally alcohol is another drug that works in that same system, is that they anesthetize our limbic system. In other words, we're not as attuned to the people around us while we're taking them, and that works both ways. I mean, we don't heal, and we continue to be focused on our own internal processes more than is probably healthy. So I think what Peter said earlier about working with people is you have to form a relationship with a physician, and you have to the diet has to go at the pace that the person is willing to work at, and it, you know, as Marx and Swinson showed, you know, 30 years ago, the people who rely on drugs to make changes in their behavior don't necessarily do as well as the people who connect and work with other people.
And Dr. Ritvo, as
I
you
mean,
prescribe. Oh, sorry,
Okay.
go, Dr. Martin.
Yeah, I was just going to say that I think it's really important that we look at this as a fair, you know, sort of a, we need to be kind to both patients and doctors here. Doctors don't give patients medicines to hurt them. They give them medicines because they need help, they're asking for help, and they think they can help them. And in many ways, the problem is not so much that there are medicines that are harmful. The problem is that some patients and some physicians are impatient. You know, there is a tremendous pressure not to spend time with patients. We get 10 minutes with a patient to deal with a lifelong set of problems that they're struggling with. Physicians are expected to hold a magic wand and fix people, which is impossible. Society has no idea really at what point we should identify something as normal or healthy and unhealthy. We struggle with diagnoses. I don't think anyone would argue, for example, that a person with schizophrenia, whose life is total chaos, who's hallucinating all the time, should not be on an antipsychotic medication, which allows them to have a relatively normal life. There are people with bipolar illness who can live normal lives if properly treated. I think we tend to look at problems of living and pathologize them and want immediate solutions. We are an impatient society, and that is the source of why we use benzodiazepines. Benzodiazepines work really, really well, but they don't work well if that's what you take forever or for a longer period of time. There are no solutions to many problems without exploring what it is your goals in life are, what it is your expectations are, what is it your fears are. We call that psychotherapy. And there are different kinds of psychotherapy. There are psychotherapies that look into trying to understand what your motivations and what your fears are. There are psychotherapies that basically teach you techniques to relax, to focus, put your focus elsewhere. Now, these things take time and they are expensive. And our healthcare system is very eager to pay for a benzodiazepine prescription, but not to allow a doctor to spend an hour with a patient who needs that hour. So I think this is the canary in the coal mine. Benzodiazepines are the canary in the coal mine. And I am very glad that we're doing this research, but I think this is just the tip of the iceberg.
Yes, I agree with you.
Of what's wrong with our society. And that may be more than you guys want for this interview. But I think most of you agree with me to one degree or another,
Yeah.
right?
100%.
Absolutely, yeah.
Yeah. I will say, I guess on that note, that in working with patients, I mean, I now use de-identified, but small examples from patients that, I'll say, it's a marathon, not a sprint, and you don't have to agree that we don't know if and when you'll come completely off. You might be able to, but any reduction we can make will likely contribute to improvements over time. Especially I find that folks, if they know they're noticing or their loved ones are noticing cognitive impairment and memory issues or depressed mood, kind of dysphoria, that it can be really helpful. And I am able to say, hey, I have a patient I've been working with for a year, and they're now on 66% less than they were on a year ago. And they notice that they feel better, their mood's better, their family says they're more like their old selves, so they're more, vibrant and interactive. They're not having as many cognitive lapses and issues. And that has been, is very motivating and hopeful to folks. I think we can get too focused on all or nothing, or that, we want them or they want to be off tomorrow. But I think instead thinking that it's a process, and any, we'll kind of make improvements as we can. I think, again, we need to learn from the opioid epidemic with chronic pain and prescription opioids, and realize some people may not benefit from coming completely off, or may not be able to tolerate it or feel that. And so we need to make sure we don't swing the pendulum and, taper a bunch of people off too quickly. But I think we can always, engage folks in the process and give them some confidence that we're in this together. And if we can help get them on even less over a period of time, we'll probably see some improvements.
Perfect. Well, I think that's a wrap. But
Yeah,
I want to
great.
say, as someone who suffers from bind myself, and someone who works with people that suffer from bind, thank you for your work, because it really does bring a lot of validation to patients that, aren't believed maybe by their own physician or their family. It's very validating when you're going through it, especially in like the hardest part. So I just want to thank you, just from the patients that I see, people like me and Dee and Christy who have lived through it. Thank you for doing this research. Thank you.
Thank you.
All right.
Yeah, thank you.
Yeah.
To all of you.
One thing we wanted to add to the bottom here is just some acknowledgments. I want to make sure I throw these out so they're part of it. Huge thanks, as Christy's mentioned up front, to Jane McCoubrey, PhD. She, of course, created this with Christy Huff, and without her, this survey and all this work wouldn't even exist. So great thanks to her. A huge thanks to Joanne Laquan, who's been our writer. She's the writer that's written all these papers with us, and she does amazing work. And of course, to our missing team member, Bernard Silvernaill, and the Alliance for Benzodiazepine Best Practices, because they're the ones that have supported this throughout and kept the research team going. So I just want to say a special thanks to all those people, and see if anybody else wanted to add any little tidbits at the end here or anything before we close out. So, and then I'll hand it back to Angie.
Well, Dee, I want to thank you for your amazing analysis and preparation of all the tables and everything. I've never seen a study so well laid out.
Oh, wow. Thank you, Reid. I appreciate that. Thank you.
Yeah, and thank you to all of you, and especially Christy for roping everyone in along the way and sharing the process with us.
All right. Thank you, everyone, for joining us. And we'll look for the research ongoing. I'm sure it'll be in the comments or the caption to this video. Thanks again.
Thank you. Thank you for all your help, Angie.
Yeah, you're welcome.
Thanks, everybody.